You see the term, I want you to think of skin. I want you to know that we have two primary layers. We have the epidermis and the dermis. And you want to think of the epidermis as sloughing off every day. Okay, that's the one that's the most superficial. And it's going to slough off daily. The dermis is deeper. Okay, the dermis is deeper. The hypodermis lies beneath the dermis, and I want you to know that the hypodermis is not part of the skin. The hypodermis is not a part of the skin. And of course, I want you to know that it lies beneath the dermis. Thin and thick skin. I think you remember from the video, what is thin skin? Where do we find thin skin? No, that's thick. So thick skin is on the palms of our hands and the soles of our feet. But thin skin, where do we find? Well, you want to think of anything really that has hair. So basically, just about everywhere else, other than the palms of the hand and the soles of the feet. Okay. Anywhere that we have hair would be considered thin skin. The only thing I have here, the epidermis and the dermis are joined by the dermoepidermal junction. I want you to highlight that in your notes. And you don't have to memorize these numbers, but just to give you an idea of the difference between thin and thick skin. Thin skin is about 1 to 3 millimeters thick, and thick skin is 4 to 5. So quite a big difference.
Can you put that last thing?
I sure can.
Did you say the dermis is where, is what sloughs off?
Epidermis.
Epidermis.
Yes. You know, a good way to remember that is if you think of dermis, think of it as deeper. And they both start with D.
Okay.
Dermis and deeper. Mm-hmm, you bet.
Thank you.
You bet. So if we were to look at skin under the microscope, it would look something like this. The top layer would be the epidermis. Remember, the most superficial. And it's going to show up as red under the microscope. And the dermis is going to be deeper, and it's going to look like a purple color. Now, I know it tells you what this is. It's thick skin. But if you didn't see that, if it wasn't there, how would you look at this picture and know that it's thick skin right off the bat?
The rigid surface and the lack of hair.
Yeah, there's no hair, right? There's no hair there. So this would be thick skin. Whoops, we have our epidermis at the top. Here's the dermoepidermal junction right here. We have the dermis, and the dermis is where we're seeing what now? The blood supply, right? So if you're talking about burns, for instance, when the dermis is involved with a burn, obviously it's much more serious. And then we have the hypodermis, which is lots of fat in the hypodermis, but we have the blood vessels as well going into the hypodermis. Just remember, hypodermis is not part of the skin. And then we have thin skin, and that's where we see these hair follicles in the thin skin. We're going to talk about these corpuscles later in the chapter, of the skin chapter. We have Pacinian corpuscles, we have Merkel corpuscles, and we'll talk about them a little bit later. So cell types in the epidermis. You know, it's strange because the epidermis is the one that, it's the thinnest layer, it sloughs off every day, but there's actually, you know, it has 5 different layers, which you would think, well, gosh, how could the epidermis have that many layers? But it does. So let's start at the top with keratinocytes. I want you to think of keratinocytes as old cells. Okay, you want to put that in your notes. They're old cells. So they're sometimes called corneocytes after they have fully keratinized. Melanocytes, I want you to know, contribute to skin color and filter ultraviolet light. And this is a really big one, epidermal dendritic cells. Epidermal dendritic cells. I want you to know that they play a role in the immune system. Remember, our skin is our first line of defense. Okay? So if our skin is damaged in any way or compromised, it can cause our patients to, their immune system can plummet because of that. So they'll be very vulnerable to infections. I want you to know that another name for epidermal dendritic cells are called Langerhans cells, and it's named after the gentleman that discovered these cells. So I want you to know that. Tactile epithelial cells, or Merkel cells, attach to the sensory nerve endings to form light touch receptors. Now, we're not there yet, but moving forward, we're going to see how we have these tactile epithelial cells. We have lots of them, for instance, in our fingertips. Because if you touch your fingertip, anywhere on your fingertip, you know exactly where you're touching, right? There's no doubt about it. On your back, though, you're not going to have as many of those Merkel cells because, you know, something could touch your back and you kind of feel something, but you're not quite sure where it's touching, okay? So, you want to think of Merkel cells as being in sensitive areas where you know exactly where you're touching. So keratinocytes constitute more than 90% of all the cells. Melanocytes are pigment-producing cells that make up about 5% of the total cells. Epidermal dendritic cells are branched antigen-presenting cells. They find antigens on bacteria and other invaders and present them to the other immune system cells for recognition and destruction. Okay, so they have a very, very important job, right? The once they come in contact with bacteria, they're going to send out a signal, and basically other cells are going to come and destroy that bacteria. Okay. And tactile epithelial cells are located in the deepest layer of the epidermis. Okay, so if you remember from lab last week with the Amoeba sisters, they talked about these different cell layers of the epidermis. I want you to know that the stratum basale, or basale, is where mitosis occurs. So I want you to put that in your notes. Stratum basale is where mitosis occurs. And for stratum spinosum, if you can just remember that it's rich in RNA, I will be happy for stratum spinosum.
Rich in what?
RNA. here about the Stratus Sally and how, it's the only place where the cells undergo mitosis, so again, I want you to know that. And the only other two that I want you to focus on is stratum lucidum and stratum corneum. So for stratum lucidum, I want you to know that they are absent in thin skin. So if they're absent in thin skin, where are we going to find them? In thick skin. So palms of the hand, soles of the feet. Stratum corneum, I want you to know, is the most superficial layer, and dead cells filled with keratin is going to represent the barrier area. And if you remember with the Amoeba sisters that she talked about keratin as they're really dead cells, but they serve a purpose because they act as a barrier for bacteria. Are we okay so far? Let me know if you have a question. Okay, so that was epidermis. Let's talk a little more about dermis. You already know it's beneath the epidermis, right? So it's deep to the epidermis. It's sometimes called true skin. I want you to know that. So the dermis is sometimes called true skin. It lies beneath and is much thicker than the epidermis. It gives strength to skin, and it serves as a reservoir storage area for water and electrolytes. I want you to know that. So let's talk about this last one. Serves as a reservoir storage area for water and electrolytes. When you're studying this material, I think that if you are able to visualize an example of this, it will help you retain the information. So a perfect example would be, let's say that we all went for a 5-mile run. I'd be dead in the first 5 steps, but let's say that we did. And let's say that we're not drinking anything at all. We're just running and we're sweating. What's going to happen to us? We're going to become very what? Dehydrated. So the skin is amazing though, because it has a reservoir storage area for water and for electrolytes. So it's going to help us for a while. But when this storage reservoir becomes depleted, then what's going to happen? Have you ever watched marathon runners? I don't know if you've ever watched them, but they will explain that when they're running and they get really dehydrated, it's like hitting a wall. And they usually fall to the ground, right? And they have cramping, they can't move. And how is the best way to get those electrolytes back? Well, yeah, but if we're not in the hospital, what's the best
Gatorade.
way? Yeah, Gatorade, Pedialyte. But we're getting smart now with our marathon runners. So what do they have every so often when they're running? They have bananas they give them, they have Gatorade, they have water, they have things, so this won't happen. Just like,
A lot of those magnesium rubs,
yeah, they will, they sure will. Anybody that, watches football, did you see my Cowboys last night? We destroyed the Giants. But they were hot on the sidelines because, running around and, and what were they giving them? Gatorade, right? Cause they gotta replenish those electrolytes really, really quick. Now that is all, how do I say? It's not a pathology, right? That's just things that can happen to us if we, become dehydrated. But now I want you to start thinking, what happens when our patients have, gastroenteritis for a few days, right? They have diarrhea, they're vomiting. What happens to these electrolytes? They plummet, right? And if they're not replenishing, that's why when you were little and you were sick, what did your mom and dad always tell you to do? Drink fluid, right? They would try to get you to drink stuff and you're like, I don't want anything. But it really did help, even if you were still throwing it up, okay? And what we see in the hospitals with elderly people and they're sick, they don't drink anything at all. So that's a double whammy, because they're not replenishing anything that the body is getting rid of. But how would we treat a severe, someone that's really, and it's called hypovolemia. That's what it's called, hypovolemia. They would come into the hospital, and what are we gonna do? Lactate bringers, right? We're gonna get that fluid back in, get those electrolytes back in. Now that all seems real easy, right? It sounds like an easy fix, and it is if it's an acute issue. But what if the patient has renal issues? Then it's not so easy to fix, right? And that's what we're going to talk about when I do the fluid and electrolyte pathology workshop for you. Because my nurses, that is something you're going to be seeing all the time. Every day you're going to be seeing patients that have an issue with these fluid and electrolyte imbalances. Because if we can't balance them, if we can't correct them, the patient's going to die, right? So this is something you're going to be seeing all the time. And the skin plays a part in maintaining that homeostasis. Okay, so we have erector pili muscles. These erector pili muscle will, when it's relaxed, the hair is relaxed. So you see that? The shaft of hair is relaxed. But if that erector pili muscle is contracted, then the hair stands up. What can cause the erector pili muscle to contract? Chills, right? If you're cold, what else? If you're scared, the hairs will stand on end. So it's all because of that erector pili muscle. Okay, dermal growth and repair. Dermal growth and repair. So unlike the epidermis, the dermis does not continually shed and regenerate itself. So during wound healing, fibroblasts begin forming an unusually dense mass of new connective fibers. If the dense mass formed by the fibroblasts during wound healing is not replaced by normal tissue, which normally it is, but if it's not, then the patient will have a scar. So what we try to do, let's say someone's in an accident and they have to have sutures. Well, we try to minimize the scarring as much as possible. So what we do, we follow the cleavage lines. And cleavage lines are patterns formed by collagenous fibers of the reticular layer of the dermis. And they look like this. So they follow these lines to, plastic surgeons to try to minimize the scarring. So that's why cleavage lines are so important. Any questions so far? Okay. The hypodermis, also called the subcutaneous layer of superficial fascia. I want you to know it's located deep to the dermis. It forms a connection between skin and other structures, but it's not a part of the skin. So highlight that in your notes, okay? I'll ask you that. It's not a part of the skin. So the hypodermis is mostly made up of loose, fibrous, and adipose tissue, along with nerves, blood vessels, and lymphatic vessels. So I want you to know what the hypodermis is made up of. Bands of fibers running through the hypodermis called skin ligaments help hold the skin to underlying structures such as deep fascia and muscles. Okay, let's talk about skin color. Skin color. The basic determinant is quantity, type, and distribution of melanin. I want you to know that. So the more melanin we have, the darker our skin. The types of melanin, we have eumelanin and pheomelanin. I want you to know both of these. So if I ask you how many types of melanin do we have, you're going to tell me 2. And then you're going to be able to recognize their names, eumelanin and pheomelanin. Eumelanin, I want you to know, are brownish to black in color, brownish to black in color, and pheomelanin is reddish in color, like orange reddish. And that's what I have here. So our skin color is not by accident. You know, if you are from an area where there's not a lot of sunlight, you tend to have lighter skin. Like if you were from Russia, their skin is very light. Where if you're from an area where it's very sunny all the time, you're gonna have darker skin, because it's all about what? Protection, right? It's all about protection. The lighter your skin, the more vulnerable you are for skin cancer, right? Now that doesn't mean that if someone has dark skin, they can't get skin cancer. That's a big misconception. Okay, anybody can get skin cancer. But again, the lighter the skin, the more vulnerable. Somebody that suffers from albinism, they are very vulnerable to skin cancer. Not only would they have to use sunscreen, but they usually will wear long sleeve shirts because, you know, for extra protection, because they're so fair. So melanin is formed by tyrosine by melanocytes. Melanocytes release melanin in packets called melanosomes. Melanosomes are ingested by surrounding keratinocytes and form a cap over the nucleus. And of course, albinism. It's a genetic mutation marked by an absence of melanin. I want you to know that. And we'll talk more about albinism in genetics. So what's the major cause of skin cancer? Yeah, the sun, right? The sun. You know, it's kind of a catch-22 because the sun is good for us. You know, we need sun for survival. We need it for vitamin D, right? But what happens, why the sun is so detrimental, is because when our skin absorbs the sun, it absorbs it in clusters. So that can cause, over time, if you stay out too long, it'll cause your skin to burn. So, we recommend that people go at least get some sun exposure for 10 to 15 minutes a day. Whether it's walking to check the mail or driving with the window down, you get some sun. It's very, very important. But, the flip side of it, we have to be careful because of skin cancer. So there's, sunscreen. When I was a kid and teenager, we didn't know anything about that. And I remember going up on the roof to be closer to the sun so I could get a tan. Yeah, it's not recommended now. So melanin, what do I want you to know here? All I want you to know here, cumulative effects of UV exposure may produce H spots. And I'll show you, that's what H spots are. They're so much fun. So, whoops. And that's usually when we see this, it's someone that spent a lot of time out in the sun. Genes affecting skin color. Again, exposure to sun, it's the type and quantity of melanin deposited in the epidermis that's going to determine the skin color. And then we have other things regarding pathologies. If someone is lacking oxygen, what might they look like? Blue, which is called cyanosis. Sometimes patients will have very red, their face will be really red. It's called a butterfly rash. Have you ever heard of that? And what is that usually indicative of? Lupus. Very, very good. Lupus. There's actually, a lot of people think that dermatologists are just for skin cancer and acne. Right? That's usually what we think about when we think about a dermatologist. But a good dermatologist actually can diagnose many different pathologies. Like leukemia, for instance. Some types of leukemia, the patient presents with a rash all over their body, and it itches, and it doesn't go away. It doesn't go away with any medications that we give them, and after doing further testing, we find out that they have leukemia. But a dermatologist would be the one to diagnose that usually. They're the ones that pick it up before anyone else. So, that's your. What about if the patient has a yellowish color? Jaundice. And what's that usually from? The liver, yes, very good. Other pigments, beta carotene can also contribute to skin color. If you eat a lot of carrots, your skin will look a little orange. I'm not kidding. We could do that in some experiment. Do you remember the Blue Man? Do you remember him? They called him the Blue Smurf or something, but he had a lot of health issues, and he drank colloidal silver. Have you ever heard of that? Anyway, it turned his skin blue. Really blue. And he did. He kind of looked like one of the Smurfs. So sometimes certain things that we ingest can change our skin color. Lipofuscin accumulates in cells that have ceased mitosis in aging skin producing the brown, yellow age spots. So what you have to look forward to? Getting old is fun. Hemoglobin color changes also occur as a result of changes in blood flow. Have you heard of Raynaud's syndrome? Or, yeah. Well, the skin color is unique with them because you think bluish, and it can be, but in a lot of cases, their fingers are actually white. And it's from, cold can trigger it.
Is that Raynaud's?
Yeah, Raynaud's,
Oh, is that how you
Raynaud's,
pronounce it?
yeah, Raynaud's.
Raynaud's.
And they, how do we treat it? I mean, what do we do? Like, let's say that I had it and my fingers started getting white.
They actually treat it with a lupus medication, don't they?
They treat it with lupus, but if we didn't have the medication, then this happened. Because it can take about 15 minutes so what you want to do is try to warm up your hands, right? To get that circulation going again. But it takes about 15 minutes for that to work, Yeah, it's really, they think there's a genetic component with that. But very, very, very interesting because it's kind of scary when the fingers go white like that. If I can find a picture, I'll show it to you. So redder skin color, when blood flow to the skin increases. Sometimes we actually see this in our patients that have high blood pressure. Usually there's no signs or symptoms with high blood pressure, sometimes a headache. But sometimes they have that reddish appearance in their skin, on their face. Cyanosis, bluish color caused by darkening of hemoglobin when it loses oxygen and gains carbon dioxide. And then of course other pigments, bile pigments and jaundice, cosmetics, tattoos. This is cyanosis. Look how blue her fingertips are. It's usually caused by emphysema, COPD, which is usually caused by, and years of
Smoking.
smoking. But that's not always the case, right? It's not always. Skin discoloration, bruising, release of red blood cells, phagocytosis of red cells by macrophages. This poor kid has 2 black eyes. How do you think maybe he got those?
His parents shouldn't have had to told him twice.
No. He got probably hit in the nose. If you get hit in the nose, you tend to have 2 black eyes. But we also have to remember that a lot of times this bruising is just the natural healing process, okay? We worry though, let's say that I fell and I hit my leg on the floor, I don't know, and I had a big hematoma, right? So a big hematoma, you're gonna see that bruising, right? And then it's going to swell, okay? So what do we worry about?
The blood clot.
Yeah, we worry about blood clots, right? So we would check for that, but then it's just going to be the normal healing process. It's going to change colors and, the swelling will go down. Functions of the skin. I want you to know all the functions of the skin, and there's quite a few. We're going to start with the main functions first. So protection. Protection is huge. Physical barrier to microorganisms. Barrier to chemical hazards. Reduces potential for mechanical trauma. protects against the excess UV exposure. So all of these, my nurses, are under protection, okay? So protection is number one for functions of the skin, and this is everything it does to protect. Okay, I just wanna make sure you get that. And then, sensation is the second one. And sensation, somatic sensory receptors detect stimuli that permit us to detect pressure, touch, temperature, pain, and other general senses. Okay, so I want you to know that. Detect pressure, touch, temperature, pain, and other general senses. Flexibility, the skin is supple and elastic, especially when we're young. Permitting change in body contours without injury. What happens to our skin as we get older? Loses its elasticity. So how would your patient present? Let's say they're 80 years old. Very, very fragile skin. So as a nurse, what do you have to do?
Be very, very careful.
Right.
Be very careful, right, with how you touch them.
Especially tape.
Oh my goodness, with tape, yes. You remember when, I don't know if maybe your father wasn't a meanie, but I remember my dad, if I had a Band-Aid on my, it was like, rip it off because it's best to get that pain out of the way, right? They're all in one. We never want to do that with our patients, right? What can we do to soften the bandage? Yeah, well, sterilized water works really, really well, okay? And you should be able to pull it off easily. What else that happens with the skin, aside from if they have a cut or, we worry, we don't want our nails to cut them. If they're falling and we go to grab them, that can, cause injury. But what else do we worry about?
Pressure.
Yes, bed sores, right? Pressure sores. So let's say that I'm 85 years old and I'm coming from a nursing home into the ER. Well, right away when you hear nursing home, what are you thinking? Pressure sores, right? So what are you gonna do? You're gonna do a what? Head to toe assessment. And if I have a little red mark on my elbow, you're gonna document it, right? I have a little red mark on the back of my head that has no hair. You're gonna document it, right? Where do we usually see pressure sores? Bony prominences, the heel, elbows, back of the head, hips, knees, right? Okay, very, very good. We're gonna actually go into more detail about these pressure sores in lab today. How often should we turn our patient? Every 2 hours, even if they throw something at you, right? Every 2 hours, they're not gonna be happy. Okay, but every 2 hours. Because you never want a patient to develop a pressure sore in your watch, right? Ever. Okay. Excretion, water, urea, ammonia, uric acid. So, by sweating, we get rid of urea, which is actually, if you have a patient that has renal issues and the doctor orders a renal panel blood work, they're gonna check that urea, right? It's called a BUN, B-U-N. They check the blood, the urea, and the nitrogen. And if that urea is high, then it's indicative that the patient has some renal issues going on. But naturally, the body will get rid of some of this by sweating. They get rid of ammonia, they get rid of uric acid, which if we have too much uric acid, what happens? It
Fusion.
so
Gout?
gout. So what happens, that uric acid, it forms crystals in every joint in the body. It usually occurs in the big toe, and it's usually in men. But you can have gout anywhere. Could be in the knees, any joint. And gout is a metabolic disorder, so we see a lot of gout in our diabetic patients, in both male and female. Okay, the next function is immunity, and that's where these phagocytic cells come in. They destroy bacteria, and those epidermal dendritic cells trigger helpful immune reaction by working with T helper cells. Okay, so those epidermal dendritic cells play a big part in immunity. And homeostasis of body temperature. To maintain homeostasis of the body temperature, heat production must equal heat loss. So skin plays a critical role in this process. And we learned that, the first week of class, second week, when we talked about homeostasis. If we get too hot, what do? Sweat. We get cold, what do? Shiver. And it's the skin that actually detects that and starts that whole negative feedback loop. Okay, hormone, the vitamin D. So exposure of skin to UV light converts, and you don't have to know all this, but dehydrocholesterol is a precursor to vitamin D. Blood transports the precursor to the liver and kidneys, where vitamin D is produced. The process and the end result fulfill the steps required for vitamin D to be classified as a hormone. So it's kind of interesting that vitamin D is both a vitamin and a hormone. Okay, so you kind of want to commit that to your memory. We'll talk about that more when we get to the endocrine system. So melanin in the skin must be dark enough to protect the skin from damage from UV radiation, destruction of folic acid, and other adverse health effects. However, if there is too much melanin, the body cannot synthesize enough vitamin D for normal function. So in that case, we're going to have to take a vitamin D supplement. And that's why when you have your blood work done, they'll check your vitamin D to see where it's at. Okay. And again, they may recommend a good supplement would be D3. That's usually what they recommend, D3. And sometimes if a woman is postmenopausal and they have osteopenia or osteoporosis, they will give them D3 and also a calcium supplement. Usually coral calcium, and you drink it, it's a liquid, and you drink like a capful every day. And along with the vitamin D3, we get pretty good results. Okay. I think this is probably a good place to stop. Because next week I want to talk about evaporation, radiation, conduction, and convection. So I think this will be a good place. Okay. Any questions about this so far? This is a long chapter. I think there's 80 plus slides, but a lot of them are pictures. And today in lab, we're going to go through some of those pictures because we're going to talk about bed sores. Okay. Any, no questions?